So historically, most patients with bulky early-stage Hodgkin lymphoma have been managed with a combination of chemotherapy followed by involved field radiation or involved site radiation as consolidation. There have been some recent studies looking at can we omit radiation, but I would say that that has been more recent and maybe not completely the standard of care at this point. So in our study, we wanted to ask the question, could we use early PET adapted response to omit radiation in patients who had a negative PET2 after 2 cycles of ABVD, and to escalate the therapy in those who were PET2 positive in whom we know the outcomes are much less favorable. So there were no new safety events that arose in either cohort. ABVD for 6 cycles has been a standard therapy for many years in the US and abroad. So we saw, as expected, neutropenia. We did not give growth factors unless patients developed febrile neutropenia. There were a significant number of patients, about 30% of patients in whom the bleomycin needed to be discontinued, which is consistent with prior experience. In terms of the escalated BIACOP, this is also a very commonly used regimen and causes a lot of cytopenias with which we have good experience. And there were few cases of febrile neutropenia and no treatment-related mortality. So when we looked at the progression-free survival in both arms, those who were PET2 negative was 93% at 3 years, and the patients who were PET2 positive and received 4 cycles of escalated BIACOP followed by radiation had surprisingly good outcomes with a 3-year progression-free survival of 90%. Moving forward, clinical trials are incorporating brentuximab vedotin and the checkpoint inhibitors, and will likely have even newer therapies. But these are being explored now in ongoing upfront clinical trials in early stage patients. So our data will provide a nice comparison for these approaches, both in terms of progression-free survival, as well as late toxicity and even cost.